Hello guys, today we are going to discuss about estrogen pharmacology. Let's get started. Production. We all know from where estrogen is being produced. It is from ovaries. Specifically speaking, graphene follicles of ovaries and corpus luteum of ovaries. Apart from that, if the female is pregnant, placenta produces a lot of estrogen and some amount of estrogen is also being produced by adrenal cortex. In males, there is small amount of estrogen circulating in blood and that is being produced partly by testes and partly by adrenal cortex. What are endogenous estrogens? These are estrogens that are being produced by our own body. There are three forms of endogenous estrogens: estradiol, estron, and estriol. Now, each of these hormones is predominant in different parts of a female life. For example, estradiol is predominant when in the reproductive age of female, while estron is predominant after the menopause of female, while estriol is predominant when the female is pregnant. Estrogen gets highly metabolized in liver. Estrogen basically has a high first pass metabolism. When estradiol, which is the most potent form of endogenous estrogen, reaches liver, it gets oxidized and it basically forms a ketone that is called as estron. And when this estron gets reduced in liver, it basically forms estriol. That is how estrogen is metabolized. And remember, out of all these three endogenous estrogens, estradiol is the most potent estrogen. Mechanism of action. We all know estrogen is a steroid hormone, and we all know steroid hormones have nuclear receptors. Why? Because steroid hormones are dissolved in plasma membrane, can easily cross them, can reach the nuclear receptors. So assume that this is a cell and this is the nucleus. These are estrogens, molecule outside. They basically cross the plasma membrane, enter inside the nucleus, and they interact with the estrogen receptor. Once they bind to the receptor, we see dimerization of estrogen receptors. These estrogen receptors. These dimerase receptors are going to interact with co-regulators, and these co-regulators, depending on whether antagonist is binding or agonist is binding, they are going to differentially with the estrogen response elements that are present in the particular genes, right, and alter the protein synthesis. So most of the actions of estrogen is through this genomic pathway. Obviously, we know whenever this pathway is going to include nuclear receptors and protein synthesis, then it is going to take time. The action of estrogen takes time. But there is one non-genomic action for estrogen, that is to increase the uterine blood flow. That occurs immediately because that is a non-genomic action. What are the effects of estrogen in our body? Number one, it increases the growth of sex organs like vagina, fallopian tubes, uterus, and all other stuff. And it is also is primarily important in the buildup of endometrium. Secondary sex characters. So estrogen is responsible for all the secondary sexual characters that develops in a female, like enlargement of breast, axillary hair, pubic hair, and all that other stuff. Apart from that, estrogen also has many metabolic effects which are very important to be discussed here. We are going to discuss three of them. One is it decreases bone resorption. How does that do it? Estrogen basically, when it interacts with osteoclast, it causes apoptosis of osteoclast. Thereby it decreases the resorption of bone. Thereby it also prevents the osteoporosis. Estrogen maintains lipid profile. By this I mean estrogen tends to increase HDL levels in blood and decrease LDL levels in blood. This is the reason why it is very rare to see cardiovascular diseases in a premenopausal women. Estrogen increases the production of clotting factors, especially 7, 8, 9, and 10. And it also decreases the levels of antithrombin 3. Thereby, it increases the incidence of venous thromboembolism. That is why you should. You should make sure that before prescribing estrogen, your patient doesn't have any past history of stroke or venous thromboembolic incidences. Who is responsible for the menstrual bleeding? Is it estrogen or progesterone? The right answer is progesterone. Progesterone withdrawal is the prime factor that is responsible for the menstrual bleeding. What are the use cases of estrogen? Look at the functions and guess for yourself. It helps in growth of sex organs and secondary sex characters. So estrogen supplementation is given in case of delayed puberty. It helps in decreasing the bone resorption. So it can be given in postmenopausal osteoporosis. It maintains the lipid profile. So it can be given prophylactically in a postmenopausal lady. It increases the clotting factor production, increases the risk of thromboembolism. This is more of a side effect that is observed in patients when you prescribe them estrogen supplementations. Excretion. Now we will discuss how is this estrogen being excreted from our body. First point that I want you guys to remember is that it undergoes significant intrahepatic circulation, right? Second point is that at the end of the day, how is estrogen excreted out of your body? It is through urines. What happens is estrogen gets a glucuronide conjugation, it becomes water soluble, and after it becomes water soluble, it is finally eventually excreted in urine. Now, estrogen, I have told you, it undergoes intrahepatic circulation. Now tell me, what is the effect of broad spectrum antibiotics in the metabolism of estrogen? What happens when you use broad spectrum antibiotics? All your intestinal flora gets decreased. Intestinal flora gets decreased. When this happens, deconjugation of estrogen decreases. So estrogen can't be absorbed from the gut lumen back into the portal circulation. Thereby, estrogen will be excreted via feces. It decreases estrogen concentration in the blood, thereby causes therapeutic failure. So be sure not to prescribe estrogen and broad spectrum antibiotics together. Can endogenous estrogens be used therapeutically? The answer is clearly no, because endogenous estrogens have high first pass metabolism. As I've already discussed, they are rapidly metabolized in liver. Second is they have low oral bioavailability. So that is why we turn towards synthetic estrogens, especially ethinyl estradiol. Especially most commonly used estrogen preparation is ethinyl estradiol. So the synthetic preparations of estrogens have excellent T-half and bioavailability. What are the therapeutic uses estrogen is being used? Primarily we use it for two purposes. One is hormone replacement therapy in case of postmenopausal women. Second is oral contraceptive pills. If it is a combined oral contraceptive pill, it will contain both estrogen and progesterone. Estrogen, by increasing the concentration of estrogen in the blood, we suppress the pituitary gonadal axis through feedback inhibition of estrogen, thereby decrease the production of luteinizing hormone. Hence, we prevent ovulation from happening. Hence, the contraceptive effect. Senile vaginitis. What happens after menopause is that estrogen levels in blood decreases. This causes atrophy of your vaginal epithelium, and thereby causes atrophic vaginitis. Now, to prevent this, we use topical preparation of estrogen along with antimicrobials. Delayed puberty, as in case of Turner syndrome or pituitary failure. We start estrogen supplementation, cyclical estrogen supplementation from 11 years of age, and we add to the therapy progesterone once the female attains once the female gets her first menstrual bleeding. Dysmenorrhea. First of all, what is dysmenorrhea? It is pain during menstruation. Now, the primary treatment for dysmenorrhea is prostaglandin synthesis blockers. Okay, what is the primary treatment for dysmenorrhea? It is prostaglandin synthesis blockers. But in severe cases, suppose when this therapy fails, then at the last resort, you can also use estrogen supplementations. What estrogen does, as I already told you, is that it prevents by decreasing luteinizing hormone level, by suppressing the pituitary gonadal axis, it decreases luteinizing hormone levels, thereby it prevents ovulation. Even though bleeding occurs, there won't be ovulation here. These are called as anovulatory bleeding or anovulatory menstruation. So these are known to be less painful when compared to the ovulatory menstruation due to their less prostaglandin synthesis. Thereby, they can be used as a last resort therapy in dysmenorrhea. Acne occurs because of the increased androgen production from the ovaries. So the same principle, when you increase the estrogen, pituitary gonadal axis is suppressed, even androgen cell production goes down, so you can get relief from acne. Dysfunctional uterine bleeding, the primary treatment is progesterone, but estrogen also has an adjuvant value here. Carcinoma prostate, it is primarily treated with GnRH analogs and androgen antagonists. GnRH, when you give it in a continuous dose, it leads to suppression of gonadotrophin release from pituitary, thereby it has a therapeutic value. Androgen antagonist, by blocking the androgen receptors present on the prostate, helps in giving relief. Here, estrogen has a adjuvant value. What are the adverse drug reactions when you use estrogen? You might get abnormal uterine bleeding, vaginal adenocarcinoma, and then endometrial cancer risk because of the tendency of estrogen to cause endometrial hyperplasia. Estrogen inhibition. So far we have discussed what are the therapeutic uses of supplementing estrogen. Now we will discuss what are the therapeutic implications of inhibiting estrogen. First of all, if I ask you, how can I inhibit estrogen in a woman's body? What are the ways? Number one, you can basically decrease the production. For that, we use aromatase inhibitor. Aromatase is the enzyme that is catalyzing the last step of estrogen production. By blocking this enzyme, we decrease estrogen production. Second way that we use, we block the estrogen receptors. Thereby, estrogen cannot exert its action to the full potential. Example for aromatase inhibitor, we have reversible aromatase inhibitors and irreversible aromatase inhibitors. Reversible example, letrozole and anastrozole. Letrozole and anastrozole. Irreversible example, exemestane. Now, how do you block receptors? So we have partial blocker, we have a full antagonist, we have SERM. Partial blocker example, clomiphene citrate. Full antagonist example, fulvestrant. So what do you mean by SERM? SERM means selective estrogen receptor modulator. So what do you mean by this fancy term? It means these compounds, depending on the tissues, they can be either estrogen and estrogen agonistic, or they can even be estrogen antagonistic. This is depending on the tissue that they act upon. Example, tamoxifen citrate, raloxifene. What is the mechanism of action of our clomiphene citrate? If you remember from the last slide, what is clomiphene citrate? It is a partial agonist of estrogen. And we all know partial agonists act as antagonists in presence of the real agonist. So here, clomiphene acts as antagonist in presence of estradiol. What is the mechanism of action? So this, let us say this is hypothalamus, this is pituitary, and this is ovary. Hypothalamus secretes gonadotrophin releasing hormone. Pituitary produces gonadotropins like follicle stimulating hormone and luteinizing hormone. In response, ovary is going to produce estrogens. So estrogen has negative feedback inhibition over pituitary and hypothalamus. When you give clomiphene citrate, now, so how is pituitary sensing this estrogen? By using estrogen receptors. Now, these estrogen receptors are being blocked by the clomiphene. Thereby, estrogen thinks there is less estrogen floating in blood. Thereby, pumps up a lot of follicle stimulating hormone and luteinizing hormone. Thereby, this luteinizing hormone forces the ovary to ovulate. Many times, this causes multiple ovulation. Multiple eggs are being ovulated together. Now, looking at the action, can you guess where is clomiphene primarily being used in case of anovulatory infertility? Because luteinizing hormone increases to crazy high levels that forces the ovary to ovulate, even in people who have anovulatory infertility. The other use is that as this causes multiple ovulation, they can be also used in egg harvesting. Egg harvesting in vitro fertilization. Clomiphene dosing. We give 50 milligram clomiphene for 5 days starting from the 5th day of menstrual cycle. This is how we dose it, right? 50 milligram per day. It's OD dosing for 5 days starting from the 5th day of menstrual cycle. For the first 1 to 2 months, this is the dose that we give. If no therapeutic effect is being seen, then for the next 2 to 3 months, we can basically double the dose. We can double the dose. And the one thing to remember here is clomiphene administration should never cross more than 6 cycles. Why do you think so? Because of its high chance of causing ovarian tumors. As we can see, it causes a multiple ovulation. This causes a lot of damage to the ovarian epithelium. So a lot of divisions occurring there. It might lead to tuberogenesis. What are the adverse drug reactions when it comes to clomiphene citrate? And how can we prevent it? Number one is multiple pregnancy. How can we prevent this adverse effect? We basically start from low dose and we gradually increase it to high dose for each cycle. For each cycle, we start from low dose and gradually move up to high dose. Ovarian carcinoma. So before starting a patient in clomiphene citrate, do a USG, check her ovary size. If they are large, if they are enlarged, do not start the therapy. Hot flushes is caused because when estrogen levels in body is low, the hypothalamus, so the thermoregulatory center present in hypothalamus thinks even normal temperature is very hot and it starts inducing sweating to cool down the body. Now this is what we mean by hot flushes or night sweats. SERMs. As I've told you, what is SERM? Selective estrogen receptor modulator. What are these? Drugs that have estrogenic effect in some tissues, anti-estrogenic effect in some other tissues. Example, tamoxifen and raloxifene. Now let us discuss the difference between tamoxifen and raloxifene. Now, as I've told you, what are these both compounds are SERM. What is SERM? Drugs that have estrogenic activity in some tissues, anti-estrogenic activity in some other tissues, right? Tamoxifen is agonistic in bone, endometrium, lipid metabolism. Raloxifene is agonistic in bone, lipid metabolism. Tamoxifen is antagonistic in breast, while raloxifene is antagonistic in both breast as well as endometrium. The difference here is endometrium. Tamoxifen is agonistic in endometrium, whereas raloxifene is antagonistic at endometrium. Now, what happens when you're agonistic at endometrium? It causes buildup of endometrium hyperplasia in prolonged use, right? So that is the thing. That is what I have written here. Tamoxifen you should be restricted within 5 years. It should never be used more than 5 years. This is because of increased incidence of endometrial carcinoma. This adverse effect is due to this agonistic action of tamoxifen, whereas raloxifene doesn't have this adverse effect because it is antagonistic at endometrium. Apart from that, raloxifene is agonistic at bone, thereby it decreases the osteoclast and decreases the bone resorption, helps in keeping our bones healthy. So it can be used in case of postmenopausal osteoporosis. This is the second line of therapy even in postmenopausal osteoporosis, whereas the first line therapy in case of postmenopausal osteoporosis is bisphosphonates. Bisphosphonates. Example, alendronate. Right? Yes. Whereas tamoxifen, the main indication for tamoxifen is ER positive, estrogen receptor positive carcinoma breast. How do we use tamoxifen therapeutically? So tamoxifen is used adjuvant to surgery chemotherapy in estrogen receptor positive postmenopausal breast cancer patients. It can be also used as a palliative treatment for breast cancer patients in postmenopausal women. Now, how do we give it in premenopausal women? How do we give it in postmenopausal women? In case of premenopausal women, the use is restricted to 5 years. And during those terms, we also give GnRH analog together. I have already told you, whenever we give GnRH analogs in a continuous fashion, it is going to inhibit the production of gonadotrophins, whereas when it is given in pulsatile fashion, it is going to induce the secretion of gonadotrophins. Here, we give it in a continuous fashion because we want to decrease gonadotrophins, we want to decrease estrogen because the breast CA is ER positive, estrogen receptor positive. In postmenopausal women, the treatment of choice when it comes to breast carcinoma has now become aromatase inhibitors. But still, if you use tamoxifen, you should be restricted to 2 years, and after 2 years, aromatase inhibitors should be used. What are these aromatase inhibitors? I've already told you, aromatase is the enzyme that is going to catalyze the final step of estrogen synthesis. By inhibiting this enzyme, you are inhibiting the estrogen synthesis throughout body. Now, what is the use of these aromatase inhibitors? Their primary indication is in postmenopausal women who have breast carcinoma, right? Who has breast carcinoma. Now, why can't they be used in premenopausal women? This is my question. Why can't aromatase inhibitors be used in premenopausal women? In premenopausal women, what happens is the ovarian aromatase is FSH dependent. The ovarian aromatase is FSH dependent. Means, let us say I give some aromatase inhibitors and block the aromatase enzyme. I block the aromatase enzyme. Now aromatase activity will come down. So as a result, what will happen? So estrogen levels in the female body will come down. This is going to cause a feedback increase in the production of follicle stimulating hormone. They are going to increase the activity of aromatase, thereby compensating for the losses, compensating for the estrogen decrease. So estrogen comes back to normal level. So that is why when you use aromatase inhibitors in a premenopausal woman, it is not as effective. But when you use it in a postmenopausal woman, as ovaries do not produce estrogen here, this effect can be escaped from. Aromatase is present in adipose tissues, ovary, breast cancer tissue. All these aromatases being inhibited when you use aromatase inhibitors. We have reversible inhibitors, we have irreversible inhibitors. Example for reversible inhibitors, we have letrozole and anastrozole. Example for irreversible inhibitors, we have exemestane.